Hi, and welcome to a new episode of Women in Data Science, hosted by Pipple Amsterdam. Today, we are very happy to give you more information about how data science or how data is used in hospitals. This event is hosted by Pipple Amsterdam, which is a consultancy data science club originally founded in Eindhoven, but also located in Amsterdam. This WITS organization is originally founded by Stanford University, and we from Pipple are very happy to give you more information about data and data science. My name is Roos. I am a data scientist for 3 years working for Pipple, and I will be your host of today. Today I'm here with Esther de Vries. Esther, how are you?
Fine, thank you.
Yeah, I'm fine as well. So one important thing to mention is that during the premiere of this webinar, you can go to our website, wits.amsterdam, and ask all your questions and put your remarks in the chat box there. Esther will be there to answer all of your questions, and I think that's everything that I needed to say to give you an idea of what is going to happen. Esther, you work for the Jeroen Bosch Hospital.
Yes.
Can you tell a bit about yourself?
Yes. Well, as you already said, my name is Esther de Vries. I'm Dutch. And I work as a pediatrician, at least I used to work as a pediatrician and immunologist. But slowly I got more and more interested in doing science and started to decrease my patient care. And these last 4 years I've been completely working in science. Related to my favorite subject, the immune system, infectious diseases, and the organization and quality of care. And this means that I am interested in getting new knowledge and finding patients with often rare diseases. And that's how I got connected to data science, because I think now that we have everything digital in the hospitals, data science might help us, but we need to go a long way to get that going.
Okay. I think before we start talking about data and data science in hospitals, can you maybe tell a little bit more about the healthcare organization in the Netherlands?
Yes, I can. The Dutch healthcare system is organized like this. You can see it over here in the slide. When you start at the bottom, you see the general population, which is, of course, everyone. And then if you have a medical problem in the Netherlands, you always go to your general practitioner. You can't go to hospitals straight away. In many countries that's different, but in the Netherlands that's the system. And it means that everyone with a medical problem or question goes to the first line of care, the general practitioner, and most of the time the general practitioner can handle the problem. But if there is a problem that can't be handled in the first line of care, you can be referred to the second line of care. This is the hospitals. And then if it's very complicated, but this is rare, you can see that in the pyramid shape here on the slide, then you can go to the third line of care, which is the university, the academic hospitals, but only very few patients ultimately are referred there. So that means that when you're looking at diseases, especially if they are not that common, that if you're looking for them in the general population, it's very difficult to find those patients because they are so rare. And this has an influence on when you are looking for ways to find those patients. For instance, with data science algorithms, because the pre-test probability of catching them is very low in the general population and increases when you go to the first, the second, and the third line.
Okay, so I know a little bit more about the Dutch healthcare organization in the Netherlands.
Yes.
Can you tell me a little bit about the hospital that you work in, so Jeroen Bosch Hospital?
Yes. Well, right here you can see the Jeroen Bosch Hospital on the slide. This is our new building. We moved there a few years ago when several hospitals in the region of the province of North Brabant came together and became one organization, and then we got the name Jeroen Bosch Hospital. Mm-hmm. And as many of you maybe know, Jeroen Bosch was a very famous medieval painter in our city. Now, the second line of care actually has 2 levels in the Netherlands. We have the regional hospitals who deliver basic care, and we have the top clinical hospitals. You can see STZ, that's how we call them in the Netherlands. But the top clinical hospitals, like the Jeroen Bosch Hospital, they deliver top clinical care, but also perform a lot of research, mainly applied research, and they do a lot of education. So doctors train their nurses, but also laboratory personnel, for instance. And they're very much busy with innovation at the moment and with really concentrating, focusing on top clinical care. So in the Jeroen Bosch Hospital, we have a policy plan for doing research in the Jeroen Bosch Academy. And we have two departments in the Jeroen Bosch Academy. One is for education, but I'm connected to the Academy department research. And we try to embed that research in the entire hospital. So our primary goal is to serve patient care and education, so the other two pillars of our top clinical hospital. And we take care to develop research lines that are in line with the hospital policy plan as a whole. So that's why we formulated 3 core themes for our research.
So what are these 3 core themes that you're focusing on?
Well, to start with, it is patient-centered outcome research. As you can see here, maybe you've heard about My Positive Health. This is a new development. A long time ago, the WHO defined health as being completely healthy, having no problem at all. That means that once you get a chronic disease, you can never be healthy again. Whereas many people living with disability or chronic disease often feel pretty healthy. And it's not only about physical well-being, it's also about other areas of life that influence whether you feel healthy or not. So My Positive Health is a development where people look also at mental health, at societal aspects, and the kind of role you can have in society. And we are trying to deliver our patient care, colored with the positive health paradigm, and are also doing research whether we succeed in that. But that is not my theme, but it is one of our themes. And the other theme is care in the network. We used to be pretty much an isolated organization as a hospital, not just us, but all the hospitals. But in modern society, you can see that all these lines have to work together to help the patient in the best way. And so I'm also interested in what I do to try to develop that within the network. But again, this is not my theme. I'm actually appointed in the Jeroen Bosch Hospital as coordinator data science. Not that I'm a data scientist. I'm primarily a doctor, but I'm developing my data science skills the past years. And because all our data are digital nowadays, we want to try to use the new developments in data science to improve the care for our patients. That is our final goal. So data science is not our primary goal, it's just a tool to reach our goal.
Can you tell a little bit more about what the focus is within this data science team?
Sure. So first of all, we have all these digital data about what we do with the patients. This can be their history, their laboratory results, their X-rays, CT scans, pulmonary function tests, and so on and so on. But we also have information more like metadata, which is like when they come, whether it's during the day or the night, whether it's in winter or in summer, which medical specialists they are visiting. And all these data together are collected in our electronic healthcare system. But we don't do anything with it to develop new knowledge from it. So the first step we want to take, and we're actually doing several use cases now, is to take the EHR, the data inside that, and to see when we look back, so retrospective research, whether we can gain knowledge from what we see there. For instance, looking back for a certain disease and seeing which patients do better, like women or men, or certain ages, or certain medication. But the problem in doing retrospective research is, of course, that you don't know why certain choices were made. So you have to be very careful in interpreting those data. And in the past, it was developed that you also always have to do trials where you really organize your population that you're testing things in. And then you also have a population using another medication or treatment or nothing at all, and you compare that. This is important, but we found out that it is not really very well applicable to patients who come to general hospitals because they are so different and they don't fit those research populations. So this retrospective research to gain more knowledge is becoming more and more important, especially now that statistical methods are also developing to be able to analyze these data.
Esther, can you give an example of how you look back using data science or statistics, or what kind of projects do you do for that?
Well, there's a lot of examples to talk about, but recently I think a very interesting one was performed by a master's student in econometrics. And he looked at the visits to the emergency department and the relation to weather data. We have a national weather organization who do forecasts, but also look back, of course, and they collect a lot of weather data about wind and temperature and rain and snow, everything. And these data are publicly available. And we combined that with the data of all the visits to the emergency department. And he tried to model that and see whether weather data could help us to predict how many patients would visit the emergency department, because it can be very quiet there, but also very crowded. And you would like to have an idea when you need more personnel. Unfortunately, the answer was yes, there is a little bit of prediction capacity in the weather data, but it's only a little bit, and actually his calendar-only model, where he looked at holidays, carnival, being the weekend or the Monday, was much more predictive. But it helped us enormously to know that how you do these kind of things, and also that, so probably it would not be a good idea to focus on the weather data anymore. But that's the retrospective part, and now we really want to go to the prospective part, so looking forward and try to get to prediction models. And here I find that actually most questions that the healthcare workers have in our hospital about this, that they would like to analyze, to perform research on, is for anomaly detection. Now we know anomaly detection, for instance, from banks who want to know when there's a fraudulent action. And the problem about anomaly detection is that it is rare, or at least not that common, so it's not always so easy to find it. And we in hospitals often have patients who are a little bit different than others because of their disease, because of their genetic background, because of the treatments they have. And what we really would like to have is a way to predict, based on the data that we already have on that patient, which patients need some extra attention because they are slightly different, because they have something unusual, or, and that's my special interest, because they actually have a rare disease that we haven't detected yet. So that's something that we really want to start working on. And some examples are rare disease detection, but also adverse events. So there are very interesting new drugs, biologicals, with which you can, for instance, very well treat diseases like rheumatoid arthritis or Crohn's disease or multiple sclerosis. At least you can do a lot for patients, but there are also, unfortunately, adverse events. And in everyday life in the hospital, we find that some patients are more vulnerable to this than others, but we can't really predict which ones are more vulnerable. And so that's why we want to develop this. And we've just started doing that. Actually, now we are working on a project with frailty in the elderly. And one of your colleagues from Pipple is working with us on that project.
So what do you do exactly within that project?
Well, elderly, that's people 70 years or older. Some of them are perfectly healthy and full of energy and lead an active life. Some are very ill, have many diseases, and that's easy to see. But there's a lot in between where actually their increasing age is already bringing them a lot of physical problems, or maybe cognitive problems, or a combination, but it's not so clear yet. And these patients are at increased risk when, for instance, you do surgery or you start certain drugs, and you want to know that beforehand. And so it would be very interesting to be able to detect those patients as being more frail than others by using the data in the electronic health record system. And that's what we're working on right now.
So I can imagine that using data science or introducing data science within a hospital, like an organization where data science is not very high on the agenda, but it's more important to actually get people better, that it introduces some new bottlenecks, some new challenges. Can you elaborate a little bit about that?
Sure. The bottlenecks is actually that we are an organization where there are no data scientists. At least there were no data scientists. Now we are trying to get some in. And doctors and nurses were trained in their profession, but they were not trained in looking at data. So for them, they know exactly what kind of problems they encounter during their work, and they know which questions have not yet been answered, like which treatment is best for this group of patients. But it's difficult for them to formulate a real good question. What exactly is your question? What exactly is the population you want to do your research on? What exactly is it that you want to know? And which data do you think will help us to answer that question? And where can we find those data? And so formulating the question is a problem, but then the translation from that question to the computer query is an even larger problem, because they are not experienced in using coding programming language. So they do not realize how important it is to be very precise and detailed when programming. So we need help for that. But this is something that is very difficult for them to understand, and that's why there is often a miscommunication between the doctors and the data scientists. Because the doctor asks a question, the data scientist starts working and comes back with a result, and the doctor says, yes, but that's not what I asked. But actually, it is what they asked, but they didn't realize that they should have asked it in a different way. And that's where my role comes in. Because I know both fields, I try to make that connection and to solve that miscommunication and by the way, educate all the healthcare professionals in this. Another bottleneck is the data quality. The data are collected for a certain purpose, that is everyday patient care. And professionals generally understand what their colleagues write down in the electronic healthcare system. But it's very difficult to get the information out of it because they use many synonyms, abbreviations, write a lot of free text instead of use structured registration. And they put it in different parts of the system where it would be easier if it was always on the same place. So there's a lot of problems with data quality, and even there's a lot of missing data because lots of things that doctors think they do not write down. But then they might themselves know what they had thought, but the computer can't find it.
It's not in the data.
No, it's not in the data. At least it wasn't written down there. And of course, now that we have the GDPR, the General Data Protection Regulation, we have to be very careful, even more than before, about privacy, which is a bottleneck on doing this kind of research. But you can find ways to organize that, but you have to involve the patients and ask them for their consent, which is a lot more organization than it used to be. And a real big problem, which is not so easy to solve, is the so-called false positive paradox. I already mentioned that when it's not a very common problem, then it's difficult to find models that can predict which patients will have that problem, because you will find, when you have a certain ability to find those patients, you always find patients with a certain increased risk for that problem. You do not find them like you have it and you don't have it. But when you have only a few true cases among a lot of non-cases, then you will find that the hits are a lot of false positives, so they're not really true cases. And this is a problem that really needs more fundamental research in the data science field, which we can't do ourselves, but which we want to start doing together with data scientists, because this hampers further development in the prediction part of our wishes.
Thank you, Esther, for telling us about how hospitals are actually using data and how they are initiating in this data science topic. Yeah. I'm really happy to see that we are making progress there within the Netherlands, and hopefully we can continue that in the future.
Yes.
We hope you learned something about how hospitals are using data and data science as well. thank you, Esther, for being our expert, female expert in this topic today.
You're welcome.
For you, really important that during this premiere of this webinar, Esther will be available to answer all of your questions or have a discussion with you on certain topics within hospital and data use. You can check that out on our website, wits.amsterdam. There you will see the chat box available and you can address all your issues. There will be more webinars coming up on the website. Be sure to check out the calendar, subscribe. And without any other thing to mention, I hope you enjoyed this webinar and thank you for watching. See you next time.